A very warm welcome to one and all who has joined us across the globe for the World Implant Expo 2021, the second edition. Myself, Dr. Shubhankar Nankhelkar, as the host for today's session, for which we have with us Honorable Dr. Arul Prakash, sir. To just give a short introduction about sir, Dr. Arul Prakash sir has completed his BDS and MDS from Ragas Dental College, and he is working as an associate professor and a postgraduate guide in the same institute. He was the speaker at the TIMS IDA midterm conference at Annamalai University and has presented various scientific presentations at various national and international conferences. He conducted many implant courses in the last few years and has trained more than 100 doctors in the field of implantology. His areas of interest lies in basal implantology and flapless procedures. He is the mentor of the Gen XT implants and chief mentor at Nelai Dental Academy, an exclusive implant training center. He also has the he is the copyright holder for Dr. Arul's 1237 principle for implant planning. It's an honor to have you, sir, with us. Thank you so much for joining us and guiding the participants and the delegates on the topic stepping stones in basal implantology. Welcome, Dr. Arun Prakash, sir.
Thank you, Doctor, for your kind introduction about me. After a very long time, after again we'll meet in webinars.
Yes,
after the COVID times. I welcome all the delegates, all the friends and faculty members from various parts of India and abroad. Today, this is I'm going to talk something about basal implantology. This is a new trend in implantology forum. This is mainly for beginners. I'm going to talk about only the basic principle and basic things about basal implantology. Yeah, we can go to that. Everybody know?
Yes, sir. Just a small request to all the participants to drop in their questions into the chat box, and we will cover it later on after sir finishes his presentation. Over to you, Dr. Arun, sir.
Yeah, thank you. I'm Dr. Arul Prakash. Okay, going to the lecture. Who can do implants? It's many confusions in the institution as well as in the practitioners. Only oral surgeons, only prosthodontists, only periodontists. I don't think so. I'm an oral pathologist. I'm doing implant in my clinic. Who have the knowledge about prosthodontic knowledge, oral surgery knowledge, and periodontic knowledge can perform implant as per the DCA norms. Okay, what is very important in implant? It's implant or anything before proceed any procedure, we need to plan or treat. We need to plan accordingly. We need a proper pre-treatment plan. Otherwise, any treatment will end with a failure. It's the same principle here. So improper treatment plan, you will lead to failure of implants. What is improper treatment plan? See, this is a conventional case. So anterior aesthetic zone, we have an implant placement very labially. It's an aesthetic zone. So it's a very difficult. Yeah.
Sorry to disturb you. You need to share the screen, sir. Your screen share is left.
1 minute. Now?
Yes, sir. Perfectly visible now.
Yes. Okay. So improper treatment planning. This is a classic example for improper treatment planning. What they did, wherever the available bone is there, the the dental surgeon place the implant. So this patient have very good bone and very labily, so they place the implant and put cover screw. So during the prosthetic procedure, he will end it with failure or some aesthetic problem. Okay, this is also another cases. It's a very close to the adjacent tooth. So anterior aesthetic zone. See, very deeply placed implants. Okay. Okay. How to go for a proper treatment planning? So for proper treatment planning, this is a patent right. It's a copyright by me. It's a Dr. Arul's 1237 principle for implant planning. Using this principle, you can identify the straightforward case. This is a main important for this principle. This is a Dr. Arul's 1237 principle for implant planning. What is one? After placement of implant, we need a 1 mm healthy bone in the labial surface and 1 mm healthy bone in the lingual surface. This is one. Two. What is two? After placement of implant, we need a space, 2 mm space between the adjacent tooth and the implant. One, healthy bone in the buccal and lingual surface. Two, we need a adjacent tooth and implant. The space between the adjacent tooth and implant is 2 mm. 3, inter-implant distance will be in 3 mm. 7, mesiodistal width and interocclusal clearance will be 7 mm. This is a 1237 principle. One is after placement of implant, we need a 1 mm buccal and 1 mm lingual bone. We need a 2 mm healthy bone from the adjacent tooth. We need 3 mm inter-implant distance and 7 mm mesiodistal width of single edentulous, and interocclusal clearance will be minimum of 7 mm to restore the tooth. This is a 1237 principle, Dr. Arul's 1237 principle. Using this principle, we can identify the straightforward case. If a case fulfill all these criteria, is called a straightforward case. For 1 mm buccal and 1 mm lingual, mesiodistal, the space between the adjacent tooth and implant 2 mm, the inter-implant distance will be 3 mm, and mesiodistal width and interocclusal space will be 7 mm. If a case fulfill all these criteria, is called a straightforward case. Anybody can do this case, right? Next. What are the investigation needed before starting an implant? You need a clinical examination, blood investigation, radiographic examination, diagnostic cast, and photograph. What are the blood investigation you need? You need to complete blood count, BTs, bleeding time, clotting time, and ESR. What are the radiographic investigation needed? We have a 2-dimension of radiograph. One is 2-dimensional imaging and 3-dimensional imaging. What is 2-dimensional imaging? We have intraoral periapical radiograph and OPG. The 3-dimensional radiograph, we have a CBCT. Why we need to go for a 3-dimensional imaging for implant planning? Yeah, 55 years female patient came to my clinic with a complaint of swelling in the mandibular right back tooth region. In the intraoral examination, there was a swelling in the obliterating the buccal sulcus. There is a intraoral periapical radiograph shows some radiolucency around the root, and we have a root resorption also. In the OPG, we have a well-defined or ill-defined radiolucency, which involves it's extending from the second molar to opposite side of first molar. Right? We have a root resorption also here. So we send the patient for a 3-dimensional image CT. We have a multiple well-defined radiolucency all over the cranium. It's a multiple myeloma. If we proceed the treatment plan by using these 2 radiographs, we may in trouble. Okay, so always for you, if you have accessible to the nearest radiographic center for say 3-dimensional imaging, better use for diagnostic evaluation. Okay, diagnostic cast. It will be useful for occlusion. how the occlusion, how many implants you are going to place, what is the interocclusal distance, inter-implant distance, everything you can identify using the diagnostic cast. What are the armamentarium useful for basal implants? We have a two armamentarium special essential for implant placement. One is physio dispenser, another one is surgical kit. Physio dispenser, everybody know it's a surgical motor with irrigation device, and we have a surgical kit. The surgical kit, we have various instruments, surgical drills and ratchet and implant drivers. In our implant system, we have minimal implant, minimal number of drills and minimal implants, is minimal ratchet and minimal kit. Okay. Why we need to know about the basal implant? The famous quote by former dean of Harvard Medical School, Sidney Bowell, is half of what you thought in medical school will be wrong in another next 10 years time. And the trouble, he said, is none of your teacher know which half is wrong. Right? So the probability of change in knowledge, the treatment modality constantly change are 30 to 100% change. For example, 20 years back, if the patient came with the pain with the decay, the only treatment is extraction. Now the treatment modality is changed. Even the patient wants, if it's maybe a root stump, also for a root canal treatment. So treatment modality changes 30 to 100%, and the diagnostic criteria is 20 to 100%. Previously, conventional radiographs, now digital, now CBCT, and it's still more frequent changes in diagnostic modalities also. In biochemistry, very little changes, 5 to 10% changes. Physiology, very rare changes, 3 to 5%. And anatomy and histology, very, very rare changes, less than 1%. Okay, why we need to this slide is very important, because we need to know the anatomy of maxilla and mandible before placement of implant. This is a age changes. At birth, the implant, the mandible will be like this. Then the childhood, in adulthood, it will be like this, and old age will be like this. See, this is an important thing here. The only area below the mandibular canal, below the canal, this area will be common and same in all ages, right? Except at birth, in all area. So why this is same, this area is called as basal bones. Okay, what is the basal implants? What is the concept behind the basal implant? Is the orthopedic principle. We have bicortical engagement. See this is engaged. This is a various number of smooth surface implants engaged from the one cortex to the other cortex, and they will load immediately, right? Okay, this is a implant used in orthopedic process. See, this is a one cortex, they extend to the another cortex. Number of implants is. So what is the difference between conventional implant and basal implant? Conventional, we have in the bone, in the mandibular maxilla, we have a crestal bone, then cancellous bone, second cortical bone. In conventional implant, we will cross the crestal and enter in the cancellous bone. No need to enter in the bicortical or cortical bone or basal bone. But in the basal implants, we need to engage the second cortex, which is called as basal bone. Otherwise, the implant will fail. What is bicortical on anchorage? What are the areas we have? We can engage we can get bicortical engagement. In the maxilla, in anterior maxilla, we have what are the basal bones? The basal bones are in the anterior maxilla, crestal bone and nasal floor and nasal spine. These are all the basal bone in the anterior maxilla. Nasal spine, nasal floor, lateral wall of nose. These are all the basal bone in the maxilla anterior region. In posterior region, zygomatic buttress, floor of maxillary sinus, anterior wall of maxillary sinus, and posterior wall of maxillary sinus are basal bone in the posterior maxilla. In the posterior most area, we have medial and lateral pterygoid plate are basal bones. In anterior maxilla, we have a nasal floor, nasal spine, lateral wall of nose are the basal bone. In posterior maxilla, zygomatic buttress anterior wall of maxillary sinus, floor of maxillary sinus, posterior wall of maxillary sinus are the basal bone. In posterior most area, medial and lateral pterygoid plate are basal bones. In mandible, we have a buccal and lingual cortical plate, crestal bone, lower border of mandible, and mylohyoid line are the basal bone. Crestal bone, lower border of mandible, buccal and lingual cortical plate, and mylohyoid line are the basal bone in the mandible. Then the maxilla, crestal, lower in maxillary, in anterior, we have a nasal floor, nasal spine, lateral wall of nose, posterior maxilla, zygomatic buttress, anterior wall of maxillary sinus, floor of maxillary sinus, posterior wall, and posterior most area, we have a lateral and medial pterygoid plate or the basal bone. In mandible, we have a crestal bone, lower border of mandible, buccal and lingual cortical plate, and mylohyoid line are the cortical or basal bone in the mandible. Why we need to know all this area? We need to engage our implants in this area, otherwise the implant will fail someday. Okay. Instead of basal implant, we are calling as a single piece implant. What are the types of single piece implant? We have two types. One is compressive type of implant. Another one is basal type of implant. Compressive type, we have a abutment, neck, and surgical post. This is an abutment, this is a neck, and we have a surgical, this is a neck, and this is a surgical post. What is compressive implant? Single piece conventional implant is called as compressive type of implant. Single piece conventional implant is called as single piece conventional implant. We have a surface treated area. Here we have a neck and abutment as a single piece. Okay, abutment and neck will be the single piece. And surgical post, we have a surface treated area, so it will induce the osseointegration. Right? We have a compressive implants. We have a abutment. It has a high precision cone. We have a 3 round indicator, 3 recesses, and its optimum sizes will be available for neck. It has a special design. The neck in compressive as well as basal, we have polished surface. We can bend the implant abutment a 15-degree angulation. If you placed in unfavorable position, you can bend the implant. Like conventional, you will use angulated abutment and multi-angulated abutment. Like this, here we will bend the abutment to the favorable position up to 15-degree angulation. Right? This is a apical part. It will be the minimal dimension. We can bypass the inferior alveolar nerve. It has a self-threading edges, self-cutting edges. So we will drill as a minor drill or minimum width drill, and we can engage the implants. Right? We have various sizes from 3.0 width to 4.5 and even 5 size implant also we have available. So minimum length is 6. And next is 6, 8, 10, 12, 14, 16, 18, and 20 lengths are available in each sizes. 3.0, 3.5, 4, 4.55, and 5.5 sizes of width will be available in a compressive implant. Okay. What are the indication for compressive implant? We can place the implant in a healed socket and non-infected extraction socket. We can use the compressive type of implant. Okay, what is basal implants? Basal implants is completely smooth surface implant. Here also the abutment is same like compressive implant. We neck also have a special polished surface. The surgical post here completely polished surface to prevent plaque and bacteria adhering to the implant neck also, as well as in the body. Implant body, we have a combined wide thread. It allows vascularity around the implant, high bone contact. It's a high bone contact implant. We have various size. Minimum size width is 3.5. The maximum is up to 10.5 and 11 size also. We have 11 size also. Width is available. We have a 3.5. The minimum length is 10 mm, 12, 14, 16, 18, 20, 22, 24, 26. Maximum of 26 size also available in the basal type of implants, right? This is a basal implant. It's a completely smooth surface implant, a neck as well as in the surgical post also in a smooth surface implant. What are the indications for this basal implant? We have surgical, we can place it in extraction socket, and periodontally compromised cases and resolved ridges, we can use these implants. What are the, again, we are going for armamentarium. This is a physio dispenser and surgical kit. Surgical kit, we have 4 drills for basal implants as well as compressive implants, and 1 incision tool, 1 torque ratchet, and 1 drill extender. We have 2 drivers. One is implant driver, another one is drill driver. These are the pilot drills. We have 2 drills for basal implants, DP 2020 and D 2020. We have a DP 2020 and D 2020. These are all the drills for basal implants. We have 2 drills, DC step 1 and DC step 2. These are all the 2 basal 2 drills for compressive type of implants. Basal implants DP 2020 and D 2020. For compressive implants, we have 2 drills. One is DC step 1 and DC step 2. DP means drill for basal, DC means drill for compressive. This is a 20 mm. 2020 means 2 mm width, and it's a pilot drill, 2 mm width with 20 mm length. We have a laser marking 6, 8, 10, 12, 14, 16, 18, 20. Up to this level, it's a 20 mm. This is a normal 2 mm drill. It's a 2 mm. This is also 20. Here also 6, 8, 10, 12, 14, 16, 18, 20. Various spots have various laser marking to measuring the implant size. This is a lancet type of drill. If you want to place this is a TP 2020 is a important drill, because if you want to place compressive as well as basal, whatever implant you want to place, you need to place the first drill is called as DP 2020, whether you are going to place a compressive as well as basal. DP 2020 is a first drill. You need to place the DP 2020. Then if you are going for basal, if you want, you need to do a osteotomy by D 2020. If you are going for a compressive, you can use DC step 1 and DC step 2. For example, if you are going to place an implant in anterior maxilla, for example, a healed socket, it's a compressive type of implant. For if you want to place a 3-0 implant, you can use the DP 2020. That is enough. You can insert a 3-0 implant in the socket, right? If you want to place an implant in anterior mandible, you need to place a DP 2020 and second drill D 2020. Then you need to place an implant. For this is a DC step 1. We have a various laser marking like this compressive convention, that is basal implant DP 2020, 6, 8, 10, 12, 14, 16, 18, and 20 respective various laser marking. The DC step 2 is a drill only only expand the crestal bone. It's otherwise called as crestal drill, because the implant taper towards apically. So if you want to place the implant in the wider diameter, if you need to place a DC step 2 or DC 5508 implant drill to enlarge only the crestal bones, right? What are the advantages of a single piece implant? We can load immediately. You can bend the abutment. It's a simple placement and prosthetic. We have a simple placement and prosthetic procedures. What are the disadvantages of basal implant? Compared to conventional implant, a no screw retain option here. Need to place more implants. Single basal is not advisable. Okay, what are the things you need to know before starting basal implant? You need to drill the crestal. You need to feel the crestal bone by drilling. and you need to know how the cancellous bone will be feel in the drilling. You need to know the second cortex by drilling, or a second cortex or basal bone. You need to feel the soft tissue perforation and adjacent tooth perforation and adjacent implant perforation, because the majority of time you will go with flapless procedure. So you will see this as a tactile sensation. You have to identify the crustal bone, cancellous bone, and second cortex. For example, if you are perforating the soft tissue, you need to feel the soft tissue, how the soft tissue perforation will be seen. Okay, the second, it's adjacent tooth perforation and adjacent implant perforation. Okay, this is a classic case of replaced by compressive type of implant. This is a strategical placement. We'll place 8 implants in the mandible, 2 implants posterior to in each side. We'll place 2 implants posterior to the canal, 2 implants anterior to the canal before the midline. The same position here also, anterior to the canal and posterior to the canal, 2 implants be replaced with immediate loading by metal ceramic restoration. We will go with metal ceramic. Various options are there: metal ceramic restoration as well as hybrid denture with bar and acrylic processes. This depends upon the interocclusal clearance as well as vertical dimension of the patients. This is another case. We'll do it. We did it in the maxilla and mandible. See, this is pterygoid. We engage in the posterior part of mandible. That's a basal bone pterygoid. And this is a see, this is a maxillary sinus, floor of maxillary sinus. This is also floor. This is in the nasal floor. We engaged it in nasal floor. So here also we'll perforate the nasal floor. Here we perforate the lower border of here we engaged in the floor of maxillary sinus. This is also floor. This is a pterygoid implants. Here we engage in the lingual cortical plate. All the areas of lingual cortical, we engage in the lingual cortical plate. So we engaged in the second cortex. This is a basal bone. All right. This is another case. This is a case can only done by basal implants. See, the patient have a microdontia, retained deciduous tooth. So it's like a syndromic patient. There is very little amount of buccolingual width of bone. We open the flap, we try, we extract the tooth. We tried through as a flapless procedure. We are not able to enter to the lower border of mandible. So we extract, we open the flap. We did a very good basal engagement. See this. After that, we did intraoral welding. It's immediate post-operative. This is a case of 10 years back. The patient. This is a sorry for a poor radiograph. It's a 10 years back patient with odontogenic diagnosed as odontogenic keratosis. 5 years back, odontogenic keratosis. They removed the cystic lesions. The surgeon did some grafting procedures or some procedure to replace the hollow space. We did it like this. We placed 4 compressive implants and we replaced the tooth. Right. So how I will convince a case? The majority of people are thinking people are practicing in a rural practice. But I'm not able to convince my patient for implant, or these people will come for implant case. What I suggest, I'm also practicing in rural area. I placed more than 1,000 implants in our clinics. So if you are ready to convince, you are ready to say all the details to your patient, the patient will ready to hear your, and they want to do it in their best. What I will say to the patient, for example, when I was before starting the implant, one of my friend asked me, how many implants you did in your clinic? I said I did minimum of 10 to 15 implants that my consultant did the case. Why you are not convincing the I told my friend, I'm not able to convince my patient for implants. Immediately he asked me how you are convincing your patient. I told him, if a patient came with partially edentulous, I will inform we have two types of restoration. One is removable, another one is fixed. In a removable, you will go for RPD. Fixed, if you want, you need to grind the adjacent tooth. Otherwise, you need to place a screw type thing in the. We need to open your. We need to place a screw in your jaw. After that, we will place a tooth. Like that, I will convince. Immediately, he says, "Why you are saying like this to the patients?" Immediately, he told me how to convince the case. This is, don't tell all these things. This is because don't tell it's a screw like this. Tell an artificial root. You lost your tooth along with the root. We are going to place an artificial root. Or artificial root, we are going to place a tooth. If you want to restore only the crown part, or if you want to replace crown as well as root part, if the patient, more than 50% of patients will agree for replace the root as well as the tooth. And don't tell you are saying you are going to drill your maxilla and mandible. We are going to place a screw like this because, for example, patient came for extraction of a tooth. We are not telling the patient we are going to give an inferior alveolar nerve block and we are tear your buccal and lingual flap and I'll take a molar forceps deeply to the bone and will remove the tooth. We are not saying, it's a simple extraction. So like that, you will convince your patient. For the implant case also, the patient surely come for implant procedure. And another one thing, initially I did a mistake. I will inform the patient after the fixed partial denture. Another one method is another one costliest method is implant. Like that, I told to the patients in the initial phase. After that, only I can identify whether the treatment is costly or not. We can't decide. The patient, don't judge a book by its cover. That's a simple thing. You convince all the patient for your all the cases, tell all the treatment protocol, ask the patient to choose the treatment protocol. All right. This is a case of basal implants in a spinal cord. See, this much of patient. This is very much used in orthopedic. So don't think it's a newer concept or a newer thing in the dentistry. It was a very long back. These implants are used. See, this is a spinal cord. The treatment for these patients for multiple basal implants they placed. See, this kind of the huge nervous systems are going there. These surgeons owned. I don't think so. The same patient undergone treatment for implant. Here only one nerve. Here a lot of motor and sensory nerves in the spinal cord. Placement by this dentist will have more fear than this neurosurgeon or orthopedic surgeon. So don't think all the cases will be complicated. If you want to see complication, you can see it in simple local infiltration of lingual artery. Don't think about that complication. You can manage it in your clinic. There's some cases we cannot do anything. In these kind of cases, we can go for another type of implant. So thinking only the particular single system of implant will help in all situation. In this type of very thin bones, we can't place a basal implant. Also, we have to go for another system called disc implant. So single implant system won't help you in all clinical situation. The one of the myth is the patient who all have the good enough bone width, they don't have the money to place the implant. If the patient have very poor bone, this patient wants to place the implant. So start the implant practice immediately. This is our team of oral surgeon radiologist and prosthodontist and periodontist and oral surgeon. This is our team, and thank you for all for your this patient listening. Thank you, the Dentist Channel Online and Dr. Subhakar. Thank you very much for your cooperation. Thank you.
Absolutely, sir. It was indeed a very concise and detailed presentation. I feel, as you said, this is for the beginners who are planning to look into basal implantology, and each and every concept and the pictures especially were very convincing, sir. Thank you so much. It was an excellent presentation. Am I audible, sir?
Yes, yes, sir. Yes, sir.
Okay, okay.
Thank you.
So before moving on to the question answer session, I would just like to brief down about the organizers of the event. The World Implant Expo 2021, which is organized by Dentist Channel Online. We have many of the legends who are present in the field of implantology on a single platform, who are guiding us since November 5th, where we have started the second edition of World Implant Expo 2021. About the organizers, Dentist Channel Online Pvt Ltd is a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses on different areas of dentistry. Being a prime member of Dentist Channel Online brings you several opportunities, accredited webinars, and dental courses. And also, all the prime members of Dentist Channel Online would be entitled with a participation certificate of the expo with 30 CPD points accredited by the State Dental Association of Rhineland-Palatinate, Germany. We also have amazing webinars coming up next in a few days and throughout the day today also. You can also save the number which is 9739368279 on your WhatsApp, and just message down your full name to get complete details of all the things that are organized by Dentist Channel Online. There are wonderful opportunities, webinars, offline courses, and ample amount of opportunities to get. We also thank our proud sponsors for the event: Mono Implant, Unicorn Dent Mart, Nova Mind, Bicon Dental Implants, Qualia Neoactive Implants, JTK Bangladesh, Simpladent, and Shastri Brothers, and many more. You can also follow us on Instagram, Facebook, and YouTube for all the recorded videos. We have ample amount of information, ample amount of knowledge, which is shared by the legends in various fields of dentistry, and you can just get onto the platform and gain the knowledge. Thank you so much. Sir, we will move on to the question answer sessions now.
Yes.
Yes. We have the first question coming up, sir. It is by Dr. Hiren Patel. The question is: after extraction of tooth, basal implant placement, is it good? Like after the extraction?
This depends upon the situation, sir. After immediate extraction and placement, in the prosthetic procedure, you will get some crustal that shrinkage, tissue shrinkage. So if you can go for a delayed placement, it will well and good. If you need to place it immediately in the anterior aesthetic zone, its placement is after extraction. You can go for a temporary restoration. After that, you have to go for a basal permanent restoration.
Yes, sir. Definitely. Next question is by Dr. Kamal Chabria. Is stability better if we give basals in pairs? And can we avoid splinting totally this way?
Splinting by we will anyway. We are going to splint this anyway. We are going to splint it by the metal with ceramic restoration. During the ceramic restoration, the stability will be better if you are place it in a two implants as a basal. It's always better if you are giving as a basal in two implants, because during if you are going to place a single implant, the basal implant will be encased only in the basal bone. It's a minimum of 1 or 2 threads will be in the basal bone. During the mastication, the anti-clockwise rotation in the implants the implant will become loose.
Okay.
So
yes, sir. Next question up is difference between basal and conventional placement criteria.
The basal and conventional placement criteria is each and every conventional placement criteria will differ, depends upon the drill sequence, and it's have own criteria. Here, basal implant, we will use a minimal drill with maximum implants. For example, we are going to place a 2.0 size drill, then we will place 3.5 size implants. Minimal drill, next size implant. So it's each and every conventional implant have sequence of drilling. For example, we'll do for a 2 mm drill, 2.5, 2.8, 3.2, the sequence of drill. Here we'll have minimum drill sequence, only a pilot drill, then the 2 mm drill, only the two drills. This is a basic placement criteria between the conventional as well as basic.
Yes, sir. Next question is, can we place single basal implants? We can connect basal implants to the adjacent teeth. Can we
Single basal is not advisable. We can connect it in some criteria, some area. For example, if you the maximum time avoid by connecting the implants to the adjacent tooth.
Okay, so it's not advisable.
Yeah.
Yes, so next one is, can you say about difference in indication for basal and compressive implants?
Basal implants, we have the difference between the in the indication.
Indication, yes. Difference in the indication for basal and compressive implants.
Basal and compressive indication. Basal is for resorptive ridges, as well as we can use immediate extraction cases. Compressive in the healed socket and non-infected extraction socket.
Yes. This is an interesting question, sir. Doctor says, I am an oral pathologist, sir. Does DCI allow oral pathologists to do implants?
It allows BDS, who are all finished BDS, can have the knowledge of prosthodontic, periodontic, and surgical skill. They can do any procedures. No DCI won't stop you to not to do any procedure in your clinic.
Yes, sir.
You can do.
Yes, sir. The last question.
If you have a valid dental state dental council registration, you can go with any treatment.
Yes, sir. Next question is, a 50 plus, I guess this is the age patient with high diabetes can go for basal, and what are the chances of infection in the long run? I guess there is a technical glitch somewhere. We will be this allow us 5 minutes. We'll definitely 2 minutes. We'll definitely connect back and get the speaker onto the platform.